Okay, welcome to our live stream from Deuk Spine Institute. Our patient is Canadian. He is from Toronto area. He's here because he's having back pain in his lower back. He's had it for years. It's affecting his quality of life. He can't do the things he wants to do without suffering and pain. He has two sources to the pain. 3 discs is one source. 3 facet joints is the other. We're going to fix both today. Starting with the discs. All right, step 1, navigate down to the L5-S1 disc on the left side. We're going to be fixing the L5-S1 disc from the left side. To do that, I use a needle and I use the x-ray machine to help me. You can see on the x-ray machine the needle is just outside the disc. AP, I want to use my second view, the front back view called the AP view, to make sure that I'm approaching the spine and going through the hole on the side of the spine where I want to. Indeed, we're a little bit lateral to that hole, so I could be a little bit more medial. Shot. Yeah, it's not too bad. Shot. Okay. And how is he? Shot. AP. I'm going to say this. It's very important that your x-ray pictures are lined up properly. Otherwise, you could be in an area you don't want to be. So it's important that you have the x-rays lined up perfectly. Yeah, I think it's pretty darn good. I might be able to get a little more medial. I'm going to try that and see what happens. How is he? Good? All right. Let me...
You okay? Yes. You okay?
Don't move.
Leg pain? Don't move. Any leg pain? No leg pain? You have leg pain.
Well, I'm not anywhere near his nerve. Shot. You having any pain?
Right now? Where is it? In his back.
Yeah. Perfect. Let us know. You're going to have a little bit of discomfort in the back. That's normal. AP. Skin numb. Give me a second, Jordan. Just giving you some more numbing medicine, okay? You're doing fantastic. It's looking good. You're doing great. Just lay still. Let us know how you're feeling, and that's all we need you to do. All right. I've given him his incision at 7 millimeters because I'm pretty happy with this needle position. Shot. Shot. One down, 3 to go. That's always the hardest, by the way. Lay still, you're doing great. All right, numb. We're going to give you some more numbing medicine. You'll feel a little sensation in your back. That's just medicine going in, okay? Don't freak out. You're doing great. Shot. It's always good when you're doing awake surgery to let the patients know everything's fine, because they don't know what's going on, and you know, when you're awake and somebody's doing things to you, it's easy to get scared and freak out. Is that it right there, Jordan? Shot. All right, it's a little higher than I want to be. Let's go a little lower. Shot. Great, that's perfect. So I should encounter the facets, and then I'm going to go just around the facet joints. I could feel his facets. They're a little bit inflamed as I'm passing them. AP, you doing all right? Yeah? Everything's going really good so far for you. Just lay still and everything will be great. Perfect. Lateral. Yeah, we're going to give you some more numbing medicine. Don't you worry. Num num. I'm giving you more medicine right now. You're doing great. Just lay still. It's going to be over before you even know it. So our patient, how long have you had back pain for?
13 years.
13 years? Off and on, 13 years? All right. Now he comes here after obviously watching our surgeries online, both he and his wife, and they're from Canada. You're doing great. Just lay still. We're almost done. I just got to navigate around these facets. Shot. So that's like a perfect trajectory, but I need to be a little bit more lateral in him. Shot. Uh-huh. The first step in the surgery is getting into the spine in exactly the right spot. And you have to have literally millimeter precision. Yeah, that's where we're operating. You're fine. He's got swelling there on the right side. You can see it. And that's really from his facet joints. Look at the facet joint. Jordan, show us the facet joint there. You guys, if you look at the tip of the needle, you could see it's right at the facet joint. Now look at that thing. It is enlarged. See it right there? Show the part by the needle. Can you see that, Henry, that bone? That shouldn't be there. That's a huge facet joint full of arthritis. That's why he's so swollen here. That's why he's in so much pain. All right. You're doing great. We're almost done. Shot. Shot. Nice. We're going to have you fixed up very soon. Just hang in there, okay? Shot. Right there at the back of the disc. I can feel the herniation. Perfect. Can you see the swelling here, Henry?
Let me check.
That's
A little bit, yeah.
That's where his facet arthritis is. It's huge. Very swollen. Blood pressure is good. Yeah. How are we doing? Are we getting it down? Yep. Yeah. Let's put a little pressure here just to reduce some of that swelling. Move your napkin or your towel. No. Gosh, we haven't used epi in a while. Ever since we figured out that it was raising blood pressure too much. Shot? Yeah, he's just got a lot of arthritis inflammation here. Shot? It's incredible. I could feel the swelling under his skin. That's why I want to make sure the blood pressure is okay. So, I've treated a lot of facet pain, and this patient has the most arthritis from his facets with swelling I've ever seen. And it's nice because he's thin. So one of the advantages of having a thin patient like him, he's muscular and thin, there's no body fat, is that you can actually see the swelling. I mean, I've never seen it so pronounced over the facets. Right side is much more swollen than left side very minimal. And this is all due to the arthritis in his facet joints. That's just killing him. We're going to fix that today. I'm really excited for him. It's going to take time for that swelling to go down. Shot? All right, we're about ready for him, Dr. Berndes. Okay. Are you almost ready?
Yep, I think so.
All right. So our next step is to do our discogram. I'm just so impressed with the swelling here. I could feel the facets. Excited for him. We're going to fix that. It's going to be great. All right. Let's get these set up. Now, he's had back pain for how long?
13 years.
13 years. So I'm going to put it right here. Lower back pain, 13 years affecting his life, right? It's gotten a lot worse in the last few years. So he lives in Canada. They don't have these treatments in Canada with the laser surgery. So he came to Deuk Spine Institute. And he's got pain coming from 1, 2, 3 discs. He's also got pain coming from 1, 2, 3 facet joints, right? And that's what's causing all the swelling over here, is arthritis in those joints. So we're going to fix these 3 discs. We're going to fix these 3 facet joints. 6 procedures, basically. Actually 7, because we're doing a bilateral at this one. You got L3-4, L4-5, L5-S1. Remember, he has herniated discs with annular tears. And he's got facet pain. Is he ready?
I think so. How you doing, my friend? You okay? He said yes, he's ready.
You having any pain right now? All right. You remember what happens next?
He watched the video.
All right. How bad is that on a scale of 1 to 10? How high does it go? 10. Is that where you get back pain? All right, we're going to fix that for you. 10 out of 10, L4-5. Look at that tear. Show us the tear, Jordan. Look at the tear here, Henry, on the x-ray. Huge tear. That's where the back pain's coming from. L4-5, 10 out of 10, concordant. Okay? Is that better? All right, sorry.
Give us a second here.
How bad is that on a scale of 1 to 10? 10. Is that where you get your back pain? L5-S1 is a 10 over 10 concordant as well. Sorry, my friend, we're going to put you to sleep in 30 seconds. How bad is that on a scale of 1 to 10? All right, sorry. You get to go to bed. Go to nighty-night. When you wake up, all that pain will be gone the rest of your life. Great news. All 3 discs are 10 out of 10 pain, which means when we fix them right now with the laser, that pain will be gone. I'm really excited for him and his wife and his family. And oh, look, he's not Canadian. He's really an American. Red, white, and blue. You're so patriotic, my friend. All right, shot. We going 4-5 first? Yeah. All right. You're doing great. That's medicine going in your arm. Everything's okay. All right. So we're going to fix the left L4-5 tear that's causing pain first. You got the 10s out of 10s, all 3? Documented? All right. Speaking of patriotic, I was watching a movie called The Patriot last night. Anybody ever see that?
It's an old movie, right?
Yeah, it's over 20 years old. 2000, I think. Mel Gibson. Heath Ledger. And a lot of people don't know that. If you're a Heath Ledger fan, The Patriot has Heath Ledger. Just lay still. Everything's okay. Let me know when I can proceed. But Heath Ledger is in the movie The Patriot. Plays Mel Gibson's son.
Young.
Yep. He is young in that movie. That may be one of his first movies. All right. We're just putting our patient a little more to sleep. I would drop the table a smidgen. Yeah. That's good. Perfect. All right, let me know when I can proceed. So far, we've lost about 1 cc of blood, about 20 drops, that's it. Yeah, he seems to be more comfortable with the whole process. We've got to bring the dilator through the tear. You guys see that? Dilator is going through the tear. Henry, let's go ahead and show our audience why do these tears in the disc cause so much pain. By the way, these tears are present with herniated disc, bulging disc, ruptured disc, protruded disc. It doesn't matter what kind of an injury you have. They all start with a tear And the pain comes from inflammation within that tear. All right, you can see how these herniations cause so much back pain with inflammation. Can you see the herniation we just pulled out?
Yes, we do.
That's a good one, huh? Look at that, that's 3 centimeters long. And it's about a half a centimeter wide. You guys doing okay? Yeah, you can lighten them up a bit. Let's get the scope back on. Up there.
It is. Let me see. Yeah.
All right.
What happened to that over there, the TV?
So that's why we have to have multiple televisions. Laser ready to go?
Yes.
All righty. Henry, when you're ready, we'll take the questions.
This first question comes from Ali on YouTube,
Yes.
and they asked, will fixing discs help automatically with restoring the curve in either the neck or the lower back?
I didn't really catch the question. I heard, will fixing disc automatically, and then I couldn't really understand.
Will fixing discs help automatically with restoring the curve in either the neck or the lower back?
I don't know. That's a great question. The curve in the neck and the back is never the problem. So I don't really pay much attention to things that aren't the problem. That's like saying, well, restoring the disc or fixing the disc fix my toenail growth rate or my eyelashes from falling out. I have no idea what the effect would be. I'm sure there's a relationship, but I don't know what it is. Doctors talk about curves all the time because that's something they can convince the patient they should have surgery for. It's very convincing when you see a curve that isn't right. But that's not the cause of symptoms. So don't be misled, is what I would tell you. Now, a lot of curves are abnormal on the MRI because of muscle spasms. That's from pain. So if you get rid of the pain, you get rid of the muscle spasms, it can definitely help with some of the curvature. Why are we flickering? Are you seeing the endoscopic feed?
Yep, you can see it.
Something going on with the TV feed. Jordan, can you identify what the issue is with the TV feeds? But what are you doing that's fixing it? If you know... All right, but let's see. So that wouldn't affect Henry, right? That would only affect these TVs? Well, not looks like it. It has to make sense. Because Henry is still seeing the feed when you guys are switching. Like when we lose the feed on these TVs, Henry's still seeing it. So the output from the scope must be going to where? Where does the output from the scope go? Where does the cable from the scope go to? It goes to the wall. And then how does it get to the TVs? After the wall? Oh, after the wall. So it's something happening after the wall, right? Jordan, if the problem persists, will you put a ticket in with Orlantec to have them come out and figure it out? All right. Henry will take some more questions.
This next question comes from, I love this name, Yun Yang Yu on YouTube.
All right.
And they asked, in one of your previous videos, you mentioned you may be developing something to help close up the annular tear faster. Have you made any headway on that?
Oh, yes, we have not made any headway. Nope. The annular tear is almost completely closed when we're done. As a matter of fact, there's only about 3 millimeters of space there. 3 millimeters. To the unaided eye, it would seem closed. So, but we can actually see with great detail, resolution, and magnification. But most people would consider it to be closed based on their standards, using an unaided eye. But we can see it's not closed. I think that we've got it down as close to humanly possible for getting the annulus to be as close to healed as we can make it at the end of the surgery. The rest is up to the patient. I don't know that human beings can create something that's going to make that small 3 millimeter tear go away faster. Yes, I am working on something, but it is still years away from bringing it to human trials or human implant. So we're going to be dealing with this situation as it is for a long time to come. We don't have any problems with the annulus healing. When you evaluate our patients after surgery, they do very well. They don't have any issues with the annulus healing. We do have some patients who do things they're not supposed to do after surgery, and they end up reherniating. And that reherniation rate is around 1%. 1 out of 100 patients will reherniate. But I could tell you it's always because they don't follow instructions. They always think they can do something they're not supposed to do. Yeah. The problem is they're feeling so good, they feel like they're healed up. Then they go and look at their incision on their back, and they see that it's healed, you know, and they think, okay, well, my incision's healed, I feel good, I must be fine. And then they go out and do something, and they reherniate. And I tried telling them, you can't use your feeling that you don't have any more pain as the determining factor for that the disc is healed. Okay, you're not going to feel the disc heal. You're just going to feel it when you reherniate. So it's best if you just avoid those strenuous activities, that bending, like I say, for 3 months for the bending, and avoid heavy lifting for the first year. If you do that, you'll be fine. You'll heal up just fine. The problem is people don't listen to my restrictions. But when they do listen, they have no problems whatsoever. All right, we're done here with our first disc. Sorry for the haziness. Any more questions?
Yes, we have another question from Ali, once more on YouTube. They asked, does that swollen facet joint go down, or do you have to do a rhizotomy?
Yeah, The swollen facet joint will eventually go away when it heals. But it will not go down today. It's going to take weeks for the swelling to go down, even months. The swelling in the facet joint has nothing to do with me. It was there before, and that's where his facet pain is coming from. So that's his body, his inflammation happening in his body. That's happening in all these people with arthritis in their joints. The joints get swollen. You've probably seen somebody with a swollen knee. If they have arthritis in their knee, you look at that knee and it's swollen up. That's hallmark of arthritis, is swelling, joint swelling, and pain of the joint. So that's what he has, arthritis in his facet joints on that right side. And we can't eliminate arthritis with surgery unless you cut the joint out and get rid of it, which we're not going to do. But you can get rid of the pain, and eventually the patient will work it out. They'll start using that joint more normally, and the arthritis will go away. The swelling will go away. The destructive part of the arthritis will never go away. In other words, the joint will never look normal again on MRI, X-ray, CAT scan. But it'll feel normal, and it'll move almost normally with this procedure we're about to do. So you can get back normal movement and normal feeling with the Deuk plasma rhizotomy. Great questions so far. I appreciate all these very nice, insightful questions that are going on. They give me an opportunity to answer things. Henry, why don't we show our audience the Deuk laser disc repair, how it works, how it goes in and actually repairs that tear. Okay, welcome back. We are starting the L5-S1 disc now. That was a 10/10 pain. When we did our discogram, it was a 10/10 pain that the patient had at this disc as well. As a matter of fact, all three discs we're fixing today were 10/10. You could see the herniation right here. It's blue. It's sitting inside the tear. We're debriding it. You could see the golden color is scar tissue and calcium. Shouldn't be there, it's abnormal. This is all very firm material. FIRM, firm as in tough. This is scarred up disc herniation. And the way it gets firm and scarred is from years of inflammation. Years. Not days, not weeks, not even months, years. This is years and years of chronic inflammation, like having a pimple on your face, hurting like the dickens for 13 years, but instead of being on your face, it's in your back. Oh, look at that piece of herniation. So remember, blue stains degenerative nucleus. That is the herniation. Only the herniation stains blue with our Deuk spine blue. Okay? Nothing else will stain blue. So when you see blue, you know you're dealing with a herniation. That's a herniation. Any questions?
Yes, this next question comes from Ali once more on YouTube. And they asked, how did you decide to do the rhizotomy in addition to the disc repair before going in?
Well, we decided to do a rhizotomy because when we saw this patient, he had disc pain and facet pain. And I told him he should do both. And he did both. That's why we did the rhizotomy and the disc repair, both. It's very common for people to come in and be diagnosed with disc pain and facet pain. We can do that either over the virtual consultation or we can do it in person. Now remember, pain is interesting because people don't have exactly the same pain all day, every day. Their pain varies and fluctuates. So sometimes you're not going to see the pain coming from the facet joints unless you have the patient's having facet pain at that moment. So we have patients that we've done surgery on where we didn't know they had facet pain. And they didn't have it when I saw them in clinic. They didn't have it on the telemed, but they get it 6 weeks later when they call us and come back and they have facet pain. And we have to treat it at that point. But in this patient's case, he had the facet pain, obviously, on exam. So I diagnosed it and I told him to treat both, disc and facet.
We have another question.
Yes.
This comes from Ali once more, but this time on Facebook.
Different alley or same alley?
Same one.
Uh-huh.
And
Well, Ellie, get all your questions out now.
they ask, I just had a cortisone injection in my shoulder. It took
Uh-huh.
away 50% of the pain. The doc says that means 50% is coming from the shoulder. The rest would be from the neck. Does this sound legitimate, or could the cortisone in the shoulder just be masking halfway downstream, and it's all coming from the neck?
You know, Ellie, that's a great question. I would, if your doctor's good, which it sounds like they probably are, and they do a shot in your shoulder joint or an area of your shoulder where they think the pain is coming from, you're right. The cortisone will eventually have a systemic effect, but they usually give you a numbing medicine in the shot, and if you experience an immediate relief of 50% of your pain, that means it's not the steroid, it's the numbing medicine. And the numbing medicine won't affect your neck, your spine. It'll only affect your shoulder. So it stands to reason then that if you experience an immediate 50% in relief, then it must be coming from your shoulder. So I would tend to agree with your doctor. I would agree that 50% of your pain could be coming from your shoulder. That's just based on the information you've given me. But I don't have any reason to disagree with that doctor. Sounds like they did a pretty good job. Now, if you did the numbing medicine right away and you did not get immediate relief, then that would maybe say that's due to the systemic effect of the steroid on your spine. In which case you would be right to be concerned that maybe it is all your neck and not your shoulder. But it's really hard for me to tell with the limited amount of information I have. But you're thinking the right way. I like the way you're thinking. Generally, when I see patients here in clinic and I'm concerned about neck pain and I see it's going into the shoulder, I will also do a shoulder exam when the patient is here. And I can tell pretty well if the shoulder is part of the problem just by doing some simple tests in the clinic with movement of the shoulder. But you're right, the shoulder is a very important cause of pain, and it can definitely cause neck pain. The biggest way shoulders cause neck pain is guarding. Patients with shoulder pain, it hurts to move their shoulder, so they hold their shoulder tight against their body. And when they do that, it really makes the muscles in the neck very sore. So you can actually get neck pain just from guarding with a shoulder injury. If I would actually talk to your shoulder doctor and see what they're recommending and do that. 'Cause it's always easier to fix a shoulder problem than it is to fix a spine problem. All right, we got about a minute left on this disc. This was a 10 out of 10 pain when we tested it, and definitely causing his typical pain, he said, the typical pain he gets every day. So I feel really good about fixing this tear. You could see the tear right there, the blue stuff. That's the tear, and that's the herniation in the tear. We want to get as much of that as we can out of there. Remember, when we do herniation surgery here at Deuk Spine and anywhere, we're never going to make your disc look normal. So don't expect it to look normal. It won't. There's no surgery in the world that will make a disc look normal. Now I will tell you this, the Chinese are doing disc transplants. I would never recommend it, ever. It is not the future. It is a bad idea. Okay? You don't need a new looking disc. And the way they're doing it is they're cutting from a dead person, they're cutting their entire disc and bones out together. So they're trying to find a normal disc, and they're literally cutting the bone above and the bone below and the disc together as a unit and transplanting. It's crazy. Absolutely crazy. Because then you've got now a transplanted organ, and now you have to be on immunosuppression the rest of your life. And the results are horrible, and the complications are horrible. This surgery right here fixes everything you need fixed, so you don't need a disc transplant. But what's the saying, that commercial on television, the advertisement? It says, just because you can doesn't mean you should. Remember the one where they blew the building up with dynamite? The demolition guys? They blew up a building with dynamite, and it says, just because you can doesn't mean you should. I guess they blew up the wrong building. In other words, just because you can blow a building up doesn't mean you should blow it up. Okay? Sometimes we have technological advances that are not really appropriate for the problems we're trying to solve. Great. Just about done. 30 more seconds here. You guys see the fat right there? That fat's from the epidural space. This is the tear we're cleaning out right here, right now. Right here, right now, Jack. Anybody know what that's from? Henry's gonna Google it.
Right here, right now, Jack?
Right here, right now, Jack.
No.
One moment.
Haha, I'll be impressed. Okay, it looks good. The S1 nerve roots, L5 nerve roots buried in fat right there. A little bit of blood vessels, but we're good. I'll give you a hint. My favorite author of all time. If you know me, you'll know who it is.
Jack London?
No?
No.
Steven Spielberg.
You got part of it right.
Yeah, right now, Jack.
Right here, right now.
Cemetery?
Oh, ye close.
Really?
Yes, it's Stephen King. Stephen King,
King.
but you don't have the right story.
It.
Not it. It's a, wasn't The Shining. Can you not find it?
The Talesman?
Yes, The Talisman. An
Talisman.
incredible story.
Yeah.
One of the best books he's ever written. Stephen King, The Talisman. I think he wrote it with Peter Straub, another accomplished horror writer. Good job, Henry.
Thank you.
You're like Sherlock Holmes of the internet, finding stuff. All this 80s pop culture.
That's what I'm best at, I think.
Any questions?
No current questions, but we do have a comment from Allie once more on Facebook saying, I have a DLDR scheduled at mid-November because I also have the disc bulges pressing on the nerves with the typical symptoms down the dermatomes. I will probably have to do both with the neck and shoulder. Add it to my bucket list.
Okay, well, yeah, I mean, we must have met you and talked to you, and I'm glad you're sharing with us, but I could probably tell you if your shoulder's having pain when you get here, you know, if your shoulder's a factor, but it sounds like it could be, and that'll just need to be a separate thing you address. All right, let's get back to this. We're doing the L4-5 right side. And then we've got one more to do. Then we're going to go to the facets. And we're actually going to end this broadcast of the DLDR, and we're going to resume it with a second broadcast for the DPR, for the facet joints. Just so we can capture that surgery as a separate surgery. So we can post it separately. We're starting to do a little more segregating the types of surgery so that the new website we're developing, which is going to be able to show people these different surgeries we do, you know, as their own sort of surgery. For example, like the Deuk laser disc repair. Shot. And the Deuk plasma rhizotomy, lumbar, cervical, thoracic. By the way, we do have a thoracic Deuk plasma rhizotomy coming up. Shot. It's not today. It is Thursday. What does Thursday look like schedule-wise anyway? Wait. Huh? What? A lot of DPR? So we're going to do it in here? Shot? Yep. All right. Well, apparently we have a lot of Deuk plasma rhizotomies Thursday in 2 days, and we're going to do them in here so we can broadcast them for you all. Luis, you're trusting me, huh? Shot? I don't trust myself. All right, that's good. So if you want to become an expert on the Deuk plasma rhizotomy procedure for facet pain, then come Thursday and watch. We're going to do a bunch of them, and we'll broadcast them. And then we'll have them on the YouTube channel. You can watch them over and over again. All right, 2 more discs to go, and then we'll move on to the facet joints. Any more questions?
Yes, this next question comes from Yun Yang Yu on YouTube.
Yin Yang, you too.
And they ask, do people have the facet problems with herniations because of loss of disc height?
No. No, they don't. Great question. So people have facet joint problems with disc problems because when you injure your disc, it's always trauma. Trauma, trauma, trauma. Remember that. It's always a traumatic event. You've done something. It's like a car accident, slip and fall, a fall off a roof, a fall on your butt, you know, something horrible that's very traumatic and it hurts your disc. You're tearing your disc. You're shearing the disc. You're shearing the annulus. You're crushing the nucleus. Well, guess what? At the same time as you do that, you're also injuring your facet joint because the facet joint is connected to the same bone as the disc. So when those two bones move, your facet's moving too. So as the disc gets torn because the bones are literally moving in opposite directions and shearing the annulus between them, you're also shearing the facet capsule. So there is a capsule around the facet joint. It's called the facet joint capsule. And the new website we're creating is going to show you all this in great detail. I've been working on it now with my team from Sweden for 6 months, and it's going to be incredible when we finally launch it. It's going to be really, really nice educational tool for everybody to use for free. But at the same time as the bones are moving and cutting, shearing the annulus, causing the annular tear and crushing the nucleus next to the tear, allowing it to become, you know, fragmented. The same time that's happening, you're actually shearing your facet joint capsule. Now the facet joints are what are called diarthrodial joints, meaning they have two bony surfaces next to each other. They've got cartilage on the surface. The cartilage is very slippery and it keeps them from grinding. But when you traumatize that facet, the facets, you're really traumatizing the surface, the cartilage surface. You're banging it hard and it chips out pieces of cartilage. It crushes the cartilage. It partially destroys the cartilage. At the same time, you're tearing the capsule. Now the capsule is holding in this liquid called synovial fluid. And the synovial fluid is a lubricant. It's like oil in an engine. And when you let the oil out of an engine, only bad things can happen, right? The parts start to rub on each other, cause friction and heat. And that's what happens. You get all this inflammation and heat and pain in your joints after you damage those facets. So the damage to the facet joint is the capsule is torn, the cartilaginous surface is damaged, the synovial fluid is leaking out, and you get this inflammation that's happening in the facets at the same time it's happening in your annulus. So people with disc injuries also injure, we call it concomitantly, at the same time, their facet joints. They never just injure their disc. But facet joints don't become painful all the time. They're painful less often. Even though they're injured, they're just not painful as often. So they're more resistant to pain, I guess, or if you want to call it that. So that's why everybody, look at that inflammatory tissue, that pink stuff, we just zapped it. That's where his pain's coming from in the disc. So I guess what I'm saying to you is the mechanism of injury is the same. It's trauma for both the disc and the facet, and you get the injury at the same time in the patient, but the facet is less likely to cause pain, and the disc is more likely. I don't know why. We haven't figured that out yet. But we've just observed that the disc is the cause of the pain 85% of the time. The facet is the cause of the pain about 10% of the time. And if you have both, when I see you, I'm going to recommend treating both. If you only have one, I'm going to recommend treating the one. You know, unless you develop the other, then we recommend treating it. That's the one thing that's disadvantage about coming to Deuk Spine, is if you have to travel here, which 80% of our patients travel here from other states, then you're going to have to come back again for a second visit to get that other area fixed. And that happens in about 10% of our patients. So 10% of our patients have other pain sources that present after they've had surgery, after they've gone home, and they have to come back and get it treated. It's the one thing I don't like about our setup, but it's something I can't prevent. All right, so far so good. I got about 2 more minutes on this disc. You guys can see we're almost done. And then we're going to move on to the last disc, and then we're going to do his facets. Once again, he's from Canada. You've all seen the movie The Man from Toronto. This is The Man from Toronto. Not really, because The Man from Toronto is Woody Harrelson, and this is not Woody Harrelson. That was a great movie. Actually, it's on Netflix right now, I think. The Man from Toronto. How many people have a Netflix subscription? Who? You do. Who else has a Netflix? You guys pay $23 a month, right?
No, $7.99. T-Mobile gives it to you free.
I don't pay a penny.
Wow. T-Mobile free. Is that right? All right, but T-Mobile may be paying for it, right? $23 a month?
We gotta stop the fixed expenses.
Huh?
We gotta cut out the fixed expenses here.
So, I heard that like Netflix has, I forgot how many million of 240 million subscribers, 247 million subscribers, something like that. Henry?
Yeah, but that's not global.
Is that
Yeah, globally.
I think it's more than that.
How many Netflix subscribers are there? I think it's like 247 million.
something like that? It was like
That's what I read.
crazy amount.
247 million. And they're paying roughly $23 a month, which means Netflix is bringing in $5.5 billion a month in subscriptions. 5.5 billion a month.
Yeah.
Huh?
They gotta pay a lot of movie rights.
They got to pay for movie rights, right? I'm not complaining. I'm just saying, you know, it's a lot of money. But if you do have a Netflix subscription, The Man from Toronto is available. And we have The Man from Toronto right here on our operating table. He'll probably get a laugh at that. All right, we're done here. And we're going to move on to the last disc, which is the L3-4, Luis. Right side L3-4. Which was a 10 out of 10, by the way. Any more questions?
No current questions.
Let me see. Looks good. I don't see anything. The nerve again is in the fat. So we're not going to see it, but it's buried in that fat. Why are nerves covered with fat? Because they're very high energy tissue and they need lots of energy, and fat is our best storage form for energy. It's the most efficient way to get energy, store energy. Fat. There's about 9.8 calories per gram of fat. That's kilocalories. Whereas carbohydrates have about 4.2 kilocalories per gram. So fat stores twice as much energy as as carbohydrates do. Plus, there's another factor about fat that you all should know when it comes to storage, is fat is hydrophobic. It does not require water. It doesn't like water. So when you store energy in the form of fat, you can store more of it, because if you're storing sugar, you need water to basically solubilize the sugar, and water is heavy. So you're going to need a lot of water to store sugar, but you need no water to store fat. So fat is light and it's packed with calories. It makes a great way to store energy for your body. There's only one tissue in your body that doesn't use fat for energy. The brain. Luis got it. The brain. The brain is the only tissue that cannot use fat. It only uses glucose, sugar. Mm-hmm. You're supposed to eat your whole weight? Your goal weight? That's such crap. You can't believe TikTok, for God's sakes. Jesus, what's going on with our country? No, really, it scares me. You know, I see all this false information out there for people. I'm scared for the world. I really am. Like, I got my knowledge from biochemistry textbooks, like real science. You know, people, I see it too. A lot of people don't appreciate a real education in somebody like me. You know, I see the comments on social media, like people with a degree versus those with common sense, and they're always putting themselves higher than the people with the degree. Well, I know there's a lot of stupid people with degrees out there. I agree with you. Agree on the degree. But I will tell you this. You are not going to be knowledgeable about the world unless you understand science. Science is the essence of life. And my education in biochemistry, there's nothing in the world, chemistry, biochemistry, cell biology, molecular biology, that I got. That's why I can do the things I do. Without that education, I wouldn't be able to discover things that are helping people. Well, we do something else here at Deuk Spine. Our patients sing to the whales. Have you ever heard a whale sing? Yes? It sounds like, right? So we commune with the whales. I love it. It's a great way to see things, you know? Anyway, getting back to the science. Folks, don't devalue science. I know we don't make as much as a hip-hop star, but scientists are important. And those who have spent the time and effort learning the truth through science, they need to be valued, and their opinions should be valued. That's all I'm going to say here. All right, Henry, any other questions?
I would believe this person is seeking advice. This comes from Marco on YouTube.
Hello, Marco on YouTube. Welcome to our live stream.
They said, I'm 37 years old and have degenerative disc disease with pain when sitting and prolonged standing walking.
Yeah.
I was told by different surgeons that they can't do anything. I don't have sciatica. Would this help me? A lot of pain and muscle spasms with any physical things that I do.
Marco, we can fix your pain with this exact surgery right here. This is what you need done, and it'll take your pain away. Yes, those surgeons are not telling you a lie. They're truthful. They cannot help you. But we can help you at Deuk Spine. The people that those surgeons can help, like you, we help. Because we know exactly where your pain's coming from. They don't. This is where your pain's coming from, right here. You see the pink, Marco, you see the pink color right there? That's inflammation. That's nerves, little nerves. You can't see them. They're microscopic. But that's where all the pain comes from. And we're using the laser to remove that inflammation. That takes the pain away permanently from your back, from the discs that we're treating. So please come here. You can send us your MRI. Henry will put the link, mri.deukspine.com. It's free. You send us your MRI images and report and set up a virtual consult with me. I will examine you and I will tell you where the pain's coming from, and we can fix it for you. Using this laser right here. All right. About 2 minutes left on this, Dr. B. Dr. B, 2 minutes on this disc. All right, Henry, in 2 minutes, we're going to shut this down, and we're going to restart a few minutes later with the Deuk plasma rhizotomy. And I'd like to spell it out, not just abbreviate DPR. I want to spell them out because I think the titling is important for searchability on YouTube.
Copy
And
that.
I want to start using the full Deuk laser disc repair, Deuk plasma rhizotomy.
Copy that.
All right. I need about 2 minutes, and we'll be done with this disc. It's all herniation here. So I started watching The Patriot last night, and I forgot what a good movie it was. It's a very good movie. If you haven't watched it, I'm starting to go back and rewatch movies that I've seen many years ago, just because there's so little good stuff, new stuff that's any good, you know? You gotta go watch the old stuff, the old movies. All right. Oh, look at that tear. Look at the pink tissue, guys. See that? That's where all the pain comes from. Marco, that's where your pain's coming from. You cannot see it on an MRI, but I could see it here. So that's why your doctors can't help you. They don't know how to do this surgery. We do it here every week, every day of the week almost. We're going to be doing it every day of the week soon. The pink stuff, that's it right there. That shouldn't be there. That's called inflammation, inflammatory tissue. It has a name, specifically called granulation tissue. Look it up on the internet. Type it up there, Henry, granulation tissue. Spelled Granulation. Granulation tissue. That's what we're dealing with here. There it is, all done. And it's worse at the periphery of the disc herniation. That's where the most blood vessels are. All right, he's going to be a very happy man when he wakes up and he doesn't have his pain anymore. He's going to go back to his hotel. He's going to go for a walk this evening on the beach here in Florida, and then he's going to want to move to Florida. Right? I have patients who literally tell me they're going to move to Florida so I can take care of them. Right? Remember clinic the other day? Were you there for that patient? They say they want to come move here so that they can be close to Deuk Spine. I tell them, don't worry, just go back to where you're from. We're not going anywhere. When you need us, we'll be here. Huh? Vacation, right? Medical tourism. I never thought I would be a medical tourist destination. Never crossed my mind. But it's just happened, you know? It's inevitable with what we do. Okay. Excellent. All done. See that? There's the fat. You can almost see every single little fat cell. You can see every fat cell. You see that? The little circles right there on there?
Yes, we do.
Each one is a fat cell. We don't even charge for getting rid of fat. It's free. But I do need to get this last bit right here. I'm going to give the scope use on this one a 6. All right? You get that? How much radiation do we use on the X-ray? Two minutes. Are you using it before I get in? Yes? I don't want to do it anymore. Just wait till I get here. Okay, you guys don't need to. I want to minimize it. All right? No more. Luis, you should know where it is. It's above the butt crack.
Yeah, I know.
Don't. No. No. No, 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 no. We should have 30 seconds of x-ray time. 30 seconds. Trust me. I know what I'm doing. No mas. No mas. All right, we're done. Take that. Oh, wait. You know what? Let me get this last thing right here. I always say we're done and then I come back. Sorry, I had to. I always look up top. I should look up top and then say we're done. All right, that's it. That's it. Done. Really done this time. Anyway, the nerve is buried in that fat. So we're not going to be messing around with it. People ask me, how do you avoid damaging the nerve? Well, it's pretty easy. The nerve is up there. We're down here. The nerve is outside the tube. We stay away from it. It's kind of like your neighbor, you know? How do you not go into your neighbor's house when you come home? Well, you know where your neighbor's door is. You know where your door is. You turn left instead of right. That's it. You know, it's not hard. Being a neurosurgeon, it's not hard. There's a lot of bad neurosurgeons out there that they damage nerves all the time. So it's not hard if you know what you're doing. I guess if I was drunk, maybe I'd accidentally go into my neighbor's house, right? So what does that say to you about neurosurgeons that accidentally damage nerves? Or something akin, right? Drunk or akin to being drunk. Point is, it shouldn't happen. It doesn't happen. I have done now 1,700 of these surgeries, an average of 2.5 discs per patient. All right? So that's 2 nerves per disc. So think about that. What's 1,700 times 2 times 2? So wait, basically 1,700 times 4, Henry. It's like 6,000. Henry, you got the number?
Yes, sir. Checking.
6,600? Something like that.
Something like this,
All
yeah.
right. So just with this surgery alone, DLDRs, I've operated next to 6,600 nerves, and I've never damaged a single one. So what does that tell you? Is it easy or hard for a good neurosurgeon to avoid nerve damage during surgery? It's easy, okay? So when you hear about nerve damage that happens, it shouldn't happen. It should not happen, period, in my opinion. So why does it happen, Shot? Well, it's just not good medicine. All right, we're doing 3, 4, 4, 5, 5, 1, correct? So I'm right near the L3 facet. I can feel it. I'm right on it. I'm wondering if I should go a little further south and aim up. I'm going to do that. Shot. So I'm going to start a little lower. I'm going to aim a little higher. That way we do less incisions. We get it all as much as we can through one incision. All right. Oh, by the way, did you stop the broadcast?
Not yet.
Oh, yeah, stop it. We're done. We're moving on to the DPR.
Copy that.